Patients with relapsed follicular lymphoma have a number of different therapeutic options. Fortunately, there's a lot of research being done in this space, which makes it a very exciting time. Personally, I think that the decision of selecting therapy at the time of relapse should be put in context of when the relapse takes place. So, given research that we've done, if relapse happens within the first 2 years of diagnosis or treatment, that is associated with a very poor prognosis for patients. So, I think that those patients should be approached slightly differently, perhaps with a more aggressive therapy, put on a clinical trial, or considering something else. But for patients that have relapse of their follicular lymphoma, after the 2-year time point, there are a number of different things. Idelalisib was recently approved for patients with relapsed and refractory follicular lymphoma. We also have obinutuzumab and bendamustine as approved for patients with relapsed and refractory follicular lymphoma.
Probably one of the most difficult decision points in treating a patient with follicular lymphoma is when a patient comes with relapse disease, because then relapse can be very, very different in different patients. And what I mean by that, patients with relapse disease can sometimes present with very asymptomatic disease that is found by accident or CT scan. They can sometimes present with transformed disease. They can sometimes present with threatened organ function or symptoms. And depending on the patient's comorbid conditions, the patient's age, as well as how it presents, those factors often influence the next line therapy. And I'll give you an example. In a patient who is fairly asymptomatic that achieves a durable remission, and I say durable 3 years plus, I often will go back to the induction regimen. For example, if patients receive single-agent rituximab, I'll just do rituximab again. If they receive bendamustine rituximab and achieved a durable remission and they don't have a lot of disease, I often will use single-agent rituximab. In patients who present with symptomatic relapse or bulky relapse, then oftentimes if the patient is healthy, I'll go back to chemotherapy. So that would mean if a patient received CHOP plus rituximab in the front line and they're presenting with bulky disease or symptomatic disease, I'll use bendamustine rituximab if they receive CHOP in the front line, or vice versa, CHOP if they receive bendamustine rituximab. In patients who progress early, it's becoming clearer that these patients represent a group with an inferior prognosis. There is data from Carla Casulo and a Lymphocare trial that suggests that patients that progress within 2 years of initial therapy tend to do worse regardless of the salvage regimen. Unfortunately, there are no studies looking specifically at that group, but if you extrapolate data from several other trials, for example, trials with a drug such as idelalisib, a PI3 kinase inhibitor, there are patients who will likely respond. And those studies, they did have patients who were refractory to prior therapy or were resistant to rituximab, and they saw responses in over 60% of patients. We also saw patients from the early bendamustine trials that were refractory to prior chemotherapy that responded, as well as patients from emerging treatments like lenalidomide rituximab who were refractory to prior regimens and responded to therapy. So I guess the punchline of all that is that in patients who relapse early, I would explore novel agents. This would mean targeted therapy or immunotherapy, because we still don't know if moving to novel agents could potentially change the natural history of these patients who traditionally have a poor prognosis.